by the 2025 IASC theme, which is pain management in low and middle income settings. So we wanted to build on that and create a conference on advancing pediatric pain care equity, addressing challenges and opportunities in low and middle income countries. We're thrilled to have, I think we have over 400 participants registered from every continent except for Antarctica. So this is the most geographically diverse group of participants and speakers we've ever had. We have a wonderful 2-day program designed ahead, and it's designed to accommodate participants from different time zones to come in and out. We're bringing together global experts in pediatric pain. Today's session features an amazing group of clinicians and researchers dedicated to improving pain care for children worldwide. I'm going to introduce our first speaker, Dr. Michael McNeil. Dr. McNeil is a combined pediatric hematology and oncology, as well as hospice and palliative care medicine physician at St. Jude's Children's Research Hospital in Memphis, where he also serves as the director of the St. Jude's Global Palliative Care Program. His research and clinical work focuses on understanding and improving palliative care in underserved communities from around the world. He leads initiatives that aims at relieving suffering of children with cancer and their families through culturally sensitive subject projects in education, implementation, and advocacy. He also continues his clinical work in pediatric oncology and palliative care, implementing evidence-based practices to advance cures and reduce suffering in children with cancer globally. On a personal note, he also has an incredibly patient wife who puts up with him and 4 active and entertaining boys who are his well. So I'm going to turn over to Mike now. Thank you.
Thank you so much for this opportunity to be here with you all today. I'm incredibly excited to hear this, and it's an incredible session, an incredible lineup over the next 2 days. And so very excited to be a part of this. And so, as mentioned, I'm going to talk a little bit about a project that I've been working on for the last couple of years and really known as the Global Comfort Promise, thinking about how we can prevent and relieve pain and anxiety associated with needle-based procedures for children with cancer and other catastrophic illnesses in low and middle income countries. Disclosures, I did receive some grant funding from our National Institutes of Health, as well as the St. Baldrick Scholar Award for this work, and that written consent provided for any patient stories and pictures. And so with that, I do want to start with the patient story. And so this is Liam, and this was taken in 2019. He was 3 years old and he had retinoblastoma. And for those of you that are familiar with pediatric oncology, retinoblastoma, if caught early, has a very high chance of cure, even in resource-constrained settings. The key caveat to that is if it's caught early or if they get regular treatment and follow-up. Liam is from Manila, and he's being treated here at Philippines General Hospital in Manila. And it was caught early. He had a good chance of survival, but there was one problem. He hated coming to the hospital. He was terrified, even getting into the car, getting ready to go each morning, because he hated the needle pokes. He was at Philippines General Hospital, they don't have the capacity for central line placement just due to infection risks and just kind of the support that's needed for there. So every single time that he went to Philippines General Hospital, they had to poke him to get lab draws and then poke him again if he made counts to be able to administer his chemotherapy. And his anxiety and fear and just pain was so severe that his mom was even considering prematurely stopping treatment to avoid these painful procedures. And so even if we have the right treatment and that we get them to the right hospital, there are patients that are stopping treatment because of pain associated with needle pokes. And so I want to talk a little bit about this comfort promise. And so this started back in 2015 with our colleagues originally at Children's Minnesota, now at UC San Francisco, Dr. Stefan Friedrichsdorf, where they did a very elegant and simple study looking at what are the most common sources of pain in children. And so they just audited the hospital. They just went across the hospital and just went to every patient room at this children's hospital and asked, are you in pain? Yes or no? What is the cause of your pain? And what helps relieve your pain? And they came away with some key findings. First, the most common source of pain were needles. That was the most painful procedure and the most common source of pain for patients. Second, there was a big discrepancy between what was recorded in the chart and what these patients were reporting in the survey. So there were, in the medical record, the scores were much lower than what the parents and patients were reporting. And then third, interestingly, what helped relieve the pain, much of it was non-pharmacologic in nature. Having the patients and parents engaged in decision making, distraction techniques, positioning techniques, as opposed to just using pharmacologic therapy. And so this was really interesting to kind of see just where those needs are in pediatric pain management. Now, just to think that this isn't just something that happens in the United States or in high income contexts. This study has been replicated here in a tertiary hospital in South Africa, in Pietermaritzburg, South Africa, and they found the exact same findings. First, most common source of pain are needles. Second, that there's a big discrepancy between what's recorded in the medical record and what the patients were reporting, if it's recorded in the medical record at all. And third, non-pharmacologic interventions are effective in addressing this pain. This has subsequently been done in Uruguay and in Peru and South America as well. And so Dr. Friedrichsdorf and team decided to put together a children's comfort promise, this idea, a quality improvement initiative to reduce and alleviate this needle-based procedural pain. And so they use this fishbone diagram to identify different opportunities and areas to overcome those needs, whether as well as the support in this different space. And they came up with what's now known as the Children's Comfort Promise. And this has four main interventions. One, numbing cream or topical anesthesia. Second, positioning techniques, not holding the child down, but comfort positioning. Third, distraction, pinwheels or flashing lights or phones or screens. And then breastfeeding or sucrose in children less than 12 months of age. And so this is the example of how they were able to build compliance and overall adherence to this bundle of interventions in the neonatal ICU in Children's Minnesota. And what was awesome to see is not only did they get this adherence, but it also resulted in reduced pain, improved patient and parent satisfaction, but also provider satisfaction. That there was anxieties associated with the fact that this is going to take too long, we don't have time for this, the patients don't experience pain. But what they saw is that the providers themselves also had increased satisfaction because they didn't feel like they were causing suffering to their patients. And it actually reduced the amount of time that these procedures took because you don't have the child flailing their arms or and it was a calm and serene environment, much calmer than historically. Now, I'm going to shift gears a little bit, right? So wonderful to hear about this Children's Comfort Promise, but why cancer patients and why global oncology? And so we have made huge strides in pediatric oncology care in the United States, Canada, and in Europe, where in the 70s, only about half of children with leukemia would be cured, and less than that for overall survival for all types of pediatric oncology diagnoses. Really, it was closer to 30% in the 1970s, in which children would survive their disease. That has dramatically improved over the last 50 years. And now, today, over 80% of children with cancer will survive their disease. But in low and middle income countries and resource constrained settings around the world, it is still at around 20 to 30%. And so while we've made huge strides in high income contexts, we're still really struggling to improve outcomes for children with cancer in low and middle income settings. And so really the number one predictor of whether a child will survive their disease is where they're born. And so we've been privileged here to be a part of the Global Initiative for Childhood Cancer with the World Health Organization, which was established in 2018 with the goal of improving survival, doubling that survival to at least 60% by 2030. And what I'm so grateful for is that they've included palliative care and supportive care as a part of this effort. So not only are we working to improve survival, our goal is to also reduce suffering and improve quality of life. And so what we've seen, and as I mentioned before, with the case of Liam, is that n- not only are there different factors that are important as far as access to chemotherapies or access to support, but there are causes of premature treatment abandonment, distance to the hospital, other children at home, funds that are big factors. But one of the other factors that are associated with treatment abandonment is actually painful diagnostic or therapeutic procedures. That children and their families are stopping treatment prematurely to avoid painful procedures, such as needle-based procedures. So we thought as a team, gosh, this is a simple solution with the Children's Comfort Promise. Can we potentially adapt this in resource-constrained settings around the world? And so we worked in close collaboration with global partners in co-designing a quality improvement initiative at 4 of our alliance partner sites. And so the sites were in Lima, Peru, Barretos, Brazil, Peter Marisburg, South Africa, and at the Philippines General Hospital in Manila. And to use these 4 principles and to co-design this initiative to see what is feasible in their settings. And they came together to think through what is the measurement strategy? How does the implementation strategy? How do they follow up? How does it need to be adapted in each of their settings? And it was just beautiful to kind of see how each one of these sites kind of took it and ran with it on their own. And how in the team in Brazil, they worked with the clowns to make dor, which is pain in Portuguese, disappear, and kind of working with them and coming up with songs and dances about the magic cream. In South Africa, the patients would enter, and their very first question is, when can I get the magic lotion? Because they knew that this was going to have an impact on their pain. But what I love is that, if, for example, in Philippine General Hospital, they actually named their initiative uh, the Liam Initiative in honor of Liam himself. And my Tagalog is not very good, but what they've told me is that the Liam, the acronym, actually stands for, translates into always thinking about pain. And so they did this in honor of him. And what was so cool was to see that it was successful, it was feasible, that the sites did use several of the interventions. One of the big challenges that they faced was having access to topical anesthesia, but by the time they finished, all had consistent access. There was high patient and parent satisfaction. But not only that, as I mentioned before, with the experience in Minnesota, there was high provider satisfaction with no change in time or success. And so we saw that it was feasible, and then we saw that it was something that was having an impact. And as I mentioned, and the most important, I think, to take away from this is the fact that this was co-designed with our collaborators. It wasn't something that we just gave them, but really tried to refine. And we went through this panel experience with the sites to really think about, as I mentioned, what is our goal? How will we know that it changes an improvement? What are the different types of changes that they'll try and implement in their settings? And then how can we compare and contrast? What is something that can be adaptable based off of contexts? Versus what are things that we should maintain consistently across the different settings? And so we were able to publish this last year. And so if you are interested in kind of learning about this pilot experience, you can scan the QR code here and just be able to learn a little bit about what we did. But what was interesting is that we had a few really important takeaways from this, right? First, when in doubt, ask the child. One of the first and most interesting things is when we started and they were kind of testing it, they're like, hey, we're not having any pain. 100% of the patients said no pain at all. And I was like, interesting. Let's talk through this. Let's dig a little bit deeper. And as we were discovering it, what we found out was that they were asking the parents who weren't even in the room with the child. This was in the middle of COVID, so the child was in the room getting the procedure by themselves, and they were asking the parent afterwards, did the child experience pain? And the parents like, no, they were fine. But then when we asked the child, they're like, yes, I had pain. It was horrible. This was awful. And so that was so when we started asking the child, that changed kind of the result. So really trying to make sure as much as possible we ask the patient themselves. The second part is something known as Goodhart's law. This is a law, this is a principle in economics that said when a measure becomes a goal, it ceases to become a good measure. And what we saw is that because of that anxiety associated with the numbing cream, we just said, all right, well, at least 2 of the interventions are important. And so they did really, really good at getting, especially distraction and positioning techniques. But even when they started getting consistent access to topical anesthesia, they weren't using it because their main goal was at least 2, and they were reaching that goal. So then when we shifted to say, hey, we really need to try and implement all of the components of the bundle, they started implementing the topical anesthesia more consistently, and we saw an even more drastic improvement in the report of pain, and that culture is key. That it wasn't just something where we give them a package and they implement it, but how to integrate that into the culture of the institution, how to be able to address these needs and adapt it based off of the scenario was essential. So with these findings, we really wanted to try and see, is this applicable in other contexts? Is this applicable in other hospitals and countries and cultures? And really what we also saw is the importance of quality improvement education as well, is that we can talk and teach all about the global comfort promise, but without some of those key principles in quality improvement, it doesn't get that same level of traction. And so we decided to work with and collaborate with the Institute for Healthcare Improvement, which is a large international organization that specializes in QI teaching and implementation, to really see, does this meaningfully reduce pain in a variety of global contexts around the world in different practice settings. Additionally, we added a fifth step, both from kind of what we were seeing in the pilot sites, but then also from what Stefan was doing in San Francisco, as well as just kind of what we're reading in the literature. And that is the importance of effective communication, such as praise and reward, especially for children older than 24 months. We also saw too that, while the breastfeeding and sucrose was for children 12 months or less in the United States, culturally, in many cultures around the world, breastfeeding can go up to 2 years, and many cultures do that. So we provided that flexibility up to 24 months. We also created a roadmap as far as kind of the timing and how to help these institutions recognize when to apply the topical anesthesia, how to prepare the tools, thinking through the positioning techniques, when to use the asepsis, and kind of help map this out a little bit better based off of what we learned from the pilot. So we then expanded and we invited an additional 22 hospitals from 18 countries around the world, trying to get global representation. As you can see, from South America, Sub-Saharan Africa, the Eastern Mediterranean, South Asia, Southeast Asia, and even a few countries in Europe. And so just again, why quality improvement for palliative care? So I talked about kind of this is a quality improvement initiative that we wanted to work with IHI with regards to this. But really when I think about palliative care, right, is the prevention and relief of suffering. And there's disease-related suffering, right? The pain and other suffering associated with the disease itself. There's the treatment related suffering that we have with regard to the treatment that we provide children with cancer, right? The radiation, the surgery, the chemotherapy can all be quite toxic and have comorbidities. And so, there's treatment, but there's also systems related suffering, and especially in resource constrained contexts. And that's what quality improvement can really address, right? Is how can we alleviate that and improve the system to reduce that suffering? We then used, for those of you that are familiar with quality improvement, there's a lot of different models and frameworks and things. We use the model for improvement, mostly because I'm just a simple man and I like simple things. And I like this model for improvement because it just is trying to answer three main questions and then thinking through the plan, do, study, act, but then also Deming's theory of profound knowledge of how do you appreciate the system? Again, thinking about the culture of the institution, human behavior and psychology, variation in a system, and then that theory of knowledge. And so what we did is we worked with the IHI team and developed an 18-month curriculum in which there was a pre-implementation time period to kind of learn about the system itself, start getting some baseline data, and then 12 months of kind of teaching as far as how do you identify a problem? What is your theory of change? How do you do PDSA cycles? How do you measure that? And then importantly, once you've gotten this functioning and working, how do you sustain this? How do you then scale it and spread it to other units of the hospital as well as other institutions? We also developed a driver diagram, thinking about what are those core components that are essential to function with this. And again, this is based off of our pilot and adapted as we worked with these additional sites, ensuring access to materials and clinical space, adopting and standardized and efficient procedural pain process, improving the teamwork within an educated and engaged clinical workforce, and for me, one of the most important things, how do we co-design and actively engage patients and parents in this process? As well as some secondary drivers that feed into that primary driver to then reach our aim and our goal to reduce the pain by 50% by the end of this work. We then focused on our measures, thinking about three main areas: our outcome measures, our process measures, and our balance measures, right? With the main outcomes being, did we meaningfully reduce pain and the severe pain for our patients? And it was just beautiful to see all of these different sites all around being able to leverage their ingenuity and innovation and creativity. So in the top left, the team in Argentina leveraging bubbles, the team in the top middle and our team from Iraq having volunteers. Top right and bottom right are from India and Colombia, respectively, and having different buckets or bags of toys and gifts as far as distractions. The bottom middle from our team in Tanzania, who use signage across every unit and every room of the hospital to highlight the different components. And then in the bottom left, the team from Indonesia, who really leveraged social media, who worked on really making sure that this was community education. And so I want to just share a quick video from our team in Colombia, who highlighted some of the experience, and again, to provide some success in this space.
En la Fundación Valle del Lili hemos asumido un compromiso con el manejo del dolor en nuestros pacientes pediátricos. Gracias al apoyo de St. Jude Children's Research Hospital, desde el 2023 hemos implementado la estrategia Global Comfort Promise Project, siendo uno de 3 hospitales en Latinoamérica vinculados a este proyecto, buscando disminuir el dolor asociado a los procedimientos con agujas en nuestros pacientes pediátricos, transformando y humanizando la experiencia del paciente.
La estrategia de Global Comfort ha sido maravillosa en el sentido de que permite humanizar la atención de nuestros pacientes. Lo que hacemos es disminuir el dolor de los niños durante procedimientos que usualmente les generan ansiedad, miedo y sufrimiento, como por ejemplo la toma de exámenes o la administración de medicamentos por vía endovenosa.
Este enfoque personalizado y centrado en el paciente pediátrico fortalece la confianza entre los niños, sus padres y nuestro equipo médico y asistencial.
Para la Fundación Valle del Lili es motivo de orgullo contar con el programa Global Comfort Promise en alianza con el Hospital St. Jude de los Estados Unidos. Nosotros como institución estamos comprometidos en continuar creciendo este programa para que el 100% de nuestros niños sean manejados bajo la estrategia de disminuir el dolor.
La clave del éxito de esta estrategia radica en la perfecta coordinación de nuestro equipo y la capacitación continua para garantizar que cada procedimiento siga los más altos estándares internacionales. Con el respaldo de St. Jude, hemos integrado innovaciones como el uso de posiciones cómodas, técnicas de succión y comunicación efectiva, todo orientado a mejorar la experiencia del paciente.
La implementación de la estrategia ha sido un reto innovador, el reto de poder modificar una cultura organizacional desde el cuidado de enfermería, donde podamos llevar a los equipos a mirar los beneficios de la aplicación de las estrategias, donde podemos mejorar los tiempos de atención, la oportunidad, la calidez y la calidad de los procedimientos que se realizan.
Pero esta experiencia no la recorremos solos. Los padres juegan un papel vital en cada paso del camino, pues son ellos quienes conocen las preferencias de sus hijos. Con su colaboración, logramos que los niños y niñas no solo superen el miedo, sino que se sientan acompañados y protegidos durante todo el proceso.
Para nosotros como cuidadores o como mamás, lo más difícil es manejar el dolor de los que amamos. Entonces, ver que nuestros hijos y nuestras hijas pues ya no sufren tanto, ya no les va a quedar como ese trauma con las agujas o lo van a manejar de la mejor manera, eso da tranquilidad y confianza.
En la Fundación Valle del Lili estamos comprometidos en transformar cada experiencia médica en una experiencia memorable para la tranquilidad de los padres y el confort de nuestros pacientes pediátricos. Global Comfort Promise Project, transformando lágrimas en sonrisas. Fundación Valle del Lili, Hospital Universitario, excelencia en salud, al servicio de la comunidad.
Awesome. So what I love about that is just the ability, again, to show how they've integrated into the institution, how they've been able to spread it to other populations, and then again, how they've engaged with the medical team, not just the physicians, but the nurses, the entire staff, and then importantly as well, how they've engaged with the patients and the families themselves to be able to see what works best. And they've been able to now, and they have a manuscript under review for their experience and are spreading this to other hospitals throughout Colombia. And that's been what's really cool as well, that a team in Indonesia as well got a large grant from the Islamic Development Bank to spread to several other hospitals as well. And so just how these sites have become centers of excellence. So just a little bit with regards to the numbers of this, we had 22 hospitals, 160 healthcare professionals engaged in this. We had almost 20,000 completed forms to kind of study this and 12,000 plus needle-based procedures, virtual learning sessions, coaching calls, and work together to make sure this is sustainable. And the important question, as mentioned, is did this meaningfully reduce pain in our patients? And we saw that it did. Prior to the implementation of the Global Comfort Promise, about 2/3 or 64% of the patients reported pain with the needle-based procedure. And by the end of our sustainability phase, 32% reported pain. So we were able to reduce that pain by half. And so in the end, we had over 7,350 pain-free procedures by the end of 2024, and that has continued through 2025. A little bit about the population as well. Over half of the patients had leukemia, not surprising with the amount of needle pokes and procedures that they need. About 70% of the professionals who were doing the needle pokes were nurses, but had quite a range. We even had some psychologists and pharmacists doing this. A little over half of the patients were female. Most of these procedures were done in the outpatient setting. Importantly, too, is that while the majority of the needle pokes were peripheral IVs or lab draws, we did have almost over 5% that were doing this for intrathecal chemotherapy or lumbar punctures. And so, in some settings, they don't have anesthesia or bone marrow biopsies or intrathecal chemotherapy. And so they're doing this awake. And so having something like this can be quite helpful in their scenarios. Again, kind of the uptake of the different components. So praise or reward were there about half for sucrose or breastfeeding. Culturally, that was variable. About 60% had the topical anesthesia, and that improved over time, with the majority being consistent with age-appropriate distraction techniques and positioning techniques. What was cool as well is to see that satisfaction before and after the implementation. So you can see the strongly agree from the parents and patients themselves as far as did the team do everything in their power to address the pain, and how that meaningfully moved after implementation. Additionally, as I mentioned, looking at these things over time and the use of the topical anesthesia as that improved over time, as they got consistent access, the use of positioning and distraction techniques. Breastfeeding was quite variable just due to the smaller sample size. There weren't quite as many patients that were in the age range. And then again, there were cultural contexts, and especially in the Middle East, where breastfeeding in public is just is not acceptable. And then the use of praise or reward. But what I love is kind of seeing slowly over time how the adherence to these principles improved. And we can see how that correlates with pain. And that's really what was important, is we also looked at the different variables associated with pain. And as you can see, what was really important was that, especially topical anesthesia, that was one of the biggest issues that we faced, was kind of, well, it's expensive, we don't have access to this, or these different variables. But we're able to show that once topical anesthesia was introduced, it had a profound impact on reducing pain. These are the odds ratios of the reduction of pain and the different factors. Age-appropriate distraction techniques, praise and reward, were also important. Of note, positioning techniques were not effective in addressing pain. And we feel like there was an educational component to that as that improved over time. And so that's one of the things that we're going to explore more. Then the other important element too is when we introduced all of the elements of the bundle, and as you can see, as we looked at the introduction of the entire bundle, what that did with the odds ratio of reducing pain. And so really the key takeaway from this data is that really the complete bundle itself had the greatest odds of reducing pain. And so pain prevention is better as more elements of the package are used, and we recommend using all 5 components of the package together. That's certainly, if there was one, it's the numbing cream that would be key, but really what we saw is that it's the complete bundle that provides the best chance of reducing pain. And so it's not either or it's truly a yes and. And so there's still a lot for us to learn, right? So we're still analyzing this data from the first cohort. We've submitted the manuscript of this data. Is currently under review right now. And so we'll see kind of what's there. But we're also, as I mentioned, kind of trying to better understand why, while in the literature, positioning techniques have been shown to reduce pain, why we didn't see that in our cohort. The other thing, too, is really leveraging implementation science to understand what are the barriers and facilitators to implementation. We have interviewed the clinical teams at each of the sites to better understand what helped and what did not in the implementation. We're also looking at adaptation versus fidelity in trying to see what were those adaptations that they needed to make at their institution based off of context and culture, and how did that impact pain or not? And are there adaptations that still maintain a good impact on pain? And are there others that we need to try and avoid because it doesn't help? And then importantly, how do we make sure that this is sustainable? How do we make sure that as we kind of step back and allow them to kind of integrate this more successfully in their institutions, that it stays happening and it's not just a flash in the pan? And to expand to new institutions. And so this year we did expand to another 26 institutions around the world. So we are now in about 52 hospitals in 35 countries, continuing to learn from their experiences, continuing to learn from their successes, and to be able to try and make sure that this is something that we can create a package that they can then implement around the world. And so these are just the different sites, both from phase 1, the pilot, wave 1, wave 2, and then have been involved in different areas. And what's great as well is those sites from the pilot and wave 1 are now co-mentoring the new group. And so really that is the other key element, I think, to all of this, is the fact that it's not just us teaching these things, but now, as I mentioned before, the site in Colombia, the site in Indonesia, how they're becoming centers of excellence to then spread this knowledge to other institutions and collaborating sites in their region, in their country, and also to other patient populations beyond just childhood cancer, right? We know that children with cancer are not the only ones who get regular needle pokes. Certain cardiac conditions, children on dialysis or nephrology needs, et cetera. And so how they're able to spread this to the general pediatrics unit as well as to other hospitals. And we've even had adult providers say, hey, we could use this in the adult group as well. So in conclusion, pain with procedures is a problem for children with cancer in resource-constrained settings. The Global Comfort Promise is a feasible and effective bundle of interventions to reduce needle-based procedural pain and improve patient and provider experience. And most importantly, there are absolutely incredible and brilliant people around the globe who make the world a better place. And this is really could not have been done without the incredible work of the sites, their teams, an incredible group here at St. Jude, and as well as the regional programs, our colleagues at IHI. Special thanks to Dr. Friedrichsdorf for mentoring me in this project, as well as Dr. Justin Baker, the improvement teams at each site, and most importantly, the patients and families. So if you are interested in learning a little bit more about the Global Comfort Promise, we do have kind of cohorts each year or other activities that we do. Feel free to either email us at globalpalliativecare@stjude.org, or you can scan the QR code. But most importantly, I want to kind of conclude and leave a little bit of space for Q&A. But before I do that, I do want to close with Liam again. So this is Liam about 2 years ago. So they introduced the Global Comfort Promise, and he was able to complete therapy. They were able to get him more comfortable and excited to be able to come to the hospital, to feel more comfortable with the needle-based procedures, and he was able to complete therapy. And this is him entering kindergarten. And so just very excited to kind of see how this can have an impact on not just the patient experience, but even on outcomes more generally. So thank you so much for taking the time to listen to me today. And I think we have a few minutes for questions.
Yeah, definitely. Thank you so much for that wonderful talk, Mike, and all the exciting work that you guys are doing globally. I think we have a few minutes for questions. So if anyone has questions, I think feel free to either put your hands up on Zoom or put it into the chat box, and we're happy to read it out for you. While people are doing that, I don't see any hands up yet. Um, I was just wondering, in terms, it sounds like the topical anesthetics is one of the very useful part of your bundle, but there's obviously a lot of system issues in implementing that. Like we see with a lot of our kids, like having enough time to put it on and to make sure it works. Like, how did you guys overcome those barriers?
Yeah, so the great point. So even if they had the topical anesthesia, there were still kind of issues with uptake. And so each institution kind of came up with their own solutions. So some, what they did is as soon as the patient came in to triage, they applied the topical anesthesia right there. And so they talked with the parents and identified two of the more common sites for the needle pokes. And so had that. And then, often in these settings, there's about a 30 to 60-minute waiting period between when they get triaged and when they come in. So that by the time that they actually get from triage to the procedure room, they'd had enough time for the numbing cream to sit in. The other groups, some of them, there were a team in Brazil, I believe, I saw Carlota here from Graki in Sao Paulo. They actually trialed it with the parents themselves and gave the parents topical anesthesia to take home, and the parents were taught how to apply it, and they applied before they came to the hospital. So by the time they arrived at the hospital, that was there. And that was something, again, by learning from the families, interviewing the families, talking with the families to try and see what worked, what didn't, going from there. And the important thing too is just seeing, for some patients, especially teenagers, the teenagers said, you know what, I'm good, I'm fine. And so it's not just like, hey, we need to make sure we apply it, but offering that choice and giving them that flexibility. And some sites were like, well, we have to do it because you told us to do it. And I was like, well, it's actually giving the patients the choice. And if a teenager is saying that they'll be okay without it, you can still, say that you've offered it. And so I would say that there was flexibility and variety as far as how institutions implemented it. And we still had trouble. About 15% of the sites still consistently had issues getting regular access to it throughout the intervention. And so hopefully with this data that we now have showing its impact, we can then go back to institutional leadership. We can go to their formulary and pharmacy to say, hey, look at how important it is. And we are actually doing cost benefit analysis to be able to show the return on investment by having consistent access to it at the institution.
Thank you, Mike. Fiona, I see your hands up.
Thank you so much, Mike, and also Nai for bringing this session to us. Absolutely incredible work. My name's Fiona Campbell. I work at Sick Kids in Toronto. We had trouble even bringing Comfort Promise and implementing it at our hospital. So kudos to you to get it in such broad uptake across the globe. You mentioned that what's coming next is exploring barriers and facilitators. But for the purpose of today and people on this call, you very helpfully put in the QR code, and I'm sure there's huge resources that you've created. But what would you say is the greatest facilitator for people here who might be thinking about implementing Comfort Promise in their setting? And just one more comment, not a question, that this work that you're doing in low and middle income countries or low resource settings, this needs to be done in first world countries as well. I'm not sure we're supposed to say first world countries anymore, but there are plenty of places with all the resources in the world who are not doing the same kind of work that you are. So thanks again.
Thank you very much for that. And funnily enough, I actually tried to get our institution to be one of the pilot sites, and they said that it wasn't needed. And it wasn't until I came back with the data from what I've been doing with some of my colleagues globally that they're like, oh, this is a good idea. And so we're now implementing it now here at St. Jude, as well as some of our affiliate sites. And so I think the power of having some of that data is helpful with regards to that to show what we can learn from our colleagues globally to then help us locally. But to your point with regards to the greatest facilitator, I would say that there's two. I would say that the sites that have had the most success had buy-in from the outset from hospital leadership. and that they got the resources, they got protected time to be able to implement that. So I would say that was the first one. The second one is they had buy-in from the frontline staff. And so, when you had nurses and those that are doing the procedures, not just being told what to do, but actually being a part of the implementation team and feel like this is their project and that they have ownership of it, that also was a huge success. And so having the institutional leadership say this is a priority for us, but then also have the frontline staff feel like this is their project, they have the buy-in and they want to see it succeed, and that they felt like they were championing something, that has been wonderful. And what's been cool is to kind of see that play out with regards to the subsequent academic productivity. One of the sites in South Africa, the nurse lead actually for the first time ever at their institutional academic conference had a nurse present at the academic conference. And it was because she was leading this Global Comfort Promise initiative. And they talked a lot about how it gave kind of some of these frontline staff an opportunity to shine in ways that they haven't before. And so that was pretty cool as well. So I'd say those are the two biggest facilitators that I've seen, is that the buy-in from the institution leadership and then buy-in from the frontline staff.
Yeah, amazing. We found very similar as well. Are there any other questions? Because I have a follow-up question.
There is
Yeah,
a question in the
yeah,
chat.
Okay,
Oh,
there
yeah,
are other questions. I'm going to stand down. Thank you so much.
thanks,
yeah.
Fiona.
Like, yeah, you mentioned that 50 to 70% we can reduce the pain by taking measures. Then what are the methods used for the pain reduction? What are the methods used for?
So what we did, so you had the 5 components, right? So it was the numbing cream, positioning, distraction, breastfeeding or sucrose, and effective communication. And what we did is we had 3 forms that the sites filled out. The first was a parent and provider, or a patient and provider form, as their satisfaction form. And we try to keep that as simple as possible. And really, kind of basic demographics as far as the date, whether it was inpatient or outpatient, what their diagnosis was, and then just 3 simple questions of, did you have pain with the procedure, yes or no? And then if yes, did the team do everything in their power or did the team do everything that they could to help reduce that pain? And we had a 5-point Likert scale for that. And then if they had pain, for children over age 4, we had the Wong-Baker Faces scale to kind of calculate what their pain score was. Concurrently, we had a form that the healthcare professional filled out. And that, again, was date, time, location, so that we can kind of cross-reference. And then they filled out which were the components of the interventions that they used. Did they use distraction techniques? Did they use positioning techniques? Did they use topical anesthesia, and et cetera, et cetera? And then we asked them how they, and then other little things from a balance measure standpoint of, was the procedure successful or not? Did it take multiple attempts? Were there any complications? And then how satisfied were they with the procedure? And then we had an auditing form that was kind of an independent form that we did once a week just to kind of check in on those things. And so what we were able to do is be able to take and couple the provider form with the patient and parent form to be able to then do the analysis that I shared. And so that was kind of how we calculated that information. And so, as mentioned, we had about 12,000 procedures that we were able to then cross-reference the data to be able to look at over across the 22 sites. And we're able to kind of see those things.
Thank you. We have a comment and a question in the chat. Jennifer says, great talk, really highlights how we need to include QI methods and implementation science in healthcare provider training. Ihab says, what would you suggest instead of breastfeeding in the preoperative period before anesthesia? Are there any alternatives or other implications?
Yeah, so great question. Especially with kind of the NPO and kind of things along those lines. I would maximize the other procedures, and we actually gave kind of flexibility with the preoperative period. And so with this new wave in particular, we do have like a not applicable option to now click if it is something where they have to be NPO for a procedure. And so other options that are non-oral are just the rest of the procedures, the distraction techniques, the positioning techniques. I think, again, that topical anesthesia is essential. And then kind of that effective communication or praise or reward. And so, yes, when you are in that preoperative period and if, within the 2 hours before or less, then you can go from there. But I know that there are some changes with regards to how soon a patient can have breastfeed, or things like that beforehand. But I would say maximize the other interventions first. And that was still shown to be successful.
Great, thank you. I think given the time, we'll wrap up. So thank you so much, Mike, for the wonderful presentation. If anyone have follow-up questions or would like to continue this conversation, you can email pain.center@sickkids.ca, and you can have ability to continue the discussion. Thank you so much, Mike.
Take care, everyone. Thanks for being
Bye.
here.